Hello everyone, it is Dr. Locklear here, and I'm coming to you with Exemplar 12B and talking about type 2 diabetes. In the last recording we did type 1, which was quite lengthy. This one's not quite as we're going to talk about the pathophysiology of type 2, what happens during this particular type of diabetes, what are the causes. We're going to look at the risk factors, how to prevent it. Obesity plays a big role in type 2. We're going to look at the signs and symptoms or the clinical manifestations. We're going to look at the diagnostic test. How do we identify that it's type 2 versus type 1? How do we differentiate care of patients with type 2 across the lifespan? And you do see type 2 more in adults than you do in children. And we are going to apply the nursing process on how to assess and educate as well. So let's get started. So type 2 diabetes was formerly labeled non-insulin dependent or adult onset. A disturbingly large number of children are being diagnosed with type 2 because of early childhood obesity. This type of diabetes results from insulin resistance with a defect in the compensatory insulin secretion. Over time, the body does not produce enough insulin to keep blood glucose levels within normal limits. And again, with type 2, you do make insulin. Your body just doesn't know how to use it appropriately. So our pathophysiology is a condition of fasting hyperglycemia that occurs despite the availability of endogenous insulin. So that's insulin that is produced by the individual's own body. So again, we have insulin, we just can't use it. The level of insulin produced varies in type 2, and despite the availability, its functioning is impaired by insulin resistance. It exceeds the ability of the pancreas to compensate, and over time, the pancreas fails to produce enough insulin to meet body needs. Whatever the cause, there is insufficient production of insulin to prevent the breakdown of fats, which result in ketosis. Type 2 is characterized by a non-ketotic form of diabetes. The amount of insulin available is not sufficient to lower glucose levels. So you do have insulin over time. As the pancreas continues to destroy, you will eventually not make enough insulin. So the amount that is being made is not enough. Insulin has a decreased ability to influence glucose metabolism in people who are obese, and the uptake by the liver, skeletal muscles, and the adipose tissue can influence the metabolism of it. The exact reason is not clear, but weight loss and exercise may improve the mechanism responsible for the insulin receptors. And so when we're looking at causes, it can occur at any age, usually middle age or older, or you do see this in people who are obese, inactive, certain medications, certain illnesses like thyroid disease. You may see people as they get older and become more sedentary gain weight, and so they will have a tendency to have type 2 because of this. In obesity, insulin has decreased ability to influence glucose metabolism, so weight loss and exercise can improve this. And so what are the rates among different race and ethnicity? It's most common among American Indians and Alaskan Natives. There is research to prove that there's a genetic link of diabetes in the Native American population. Again, some of the risk factors: diabetes in parents or siblings, obesity, being sedentary, having very little physical activity, history of gestational diabetes or polycystic ovarian syndrome, hypertension, or any metabolic syndrome such as thyroid condition. Prediabetes, this is individuals at increased risk for type 2 diabetes. You have an elevated A1C, fasting blood glucose, oral glucose tolerance test, but not to diagnose levels. The risk for progression to diabetes, but it's not inevitable. So in other words, you are on the borderline. You can stop it by doing some of the preventive things. If you'll look on page 837, The risk factors really speak a lot about race and ethnicity, certain ethnic groups, people with hypertension are more prone, people that have metabolic disorders, again, such as thyroid conditions. It also lists here under metabolic syndrome hypertension, abdominal obesity, dyslipidemia, elevated C-reactive protein, and that's always a sign. Fasting blood glucose greater than 100. All of these increase the risk of type 2 diabetes, heart disease, and stroke. Studies have shown that metabolic syndrome is prevalent and increases with age and body mass index, especially if your BMI is over 30. So again, the term pre-diabetes has come into play if you have an A1C of 5.7 or higher and a fasting blood glucose between 100 and 125. So they'll do a glucose tolerance test on you to see if your sugar comes down after you eat a heavy sugar meal. What are some of the prevention? Weight loss, increase your activity, eat right. Watch your diet, watch your intake of sugars. The CDC recommends that individuals diagnosed with prediabetes participate in a CDC-approved diabetes prevention program. Just getting out walking every day. Some of the clinical manifestations: fatigue, extreme thirst, frequent urination, hunger, weight loss. Even though you're eating, but once you're obese, it's really hard to lose the weight. Infection, slow wound healing, and blurry vision. It says most people diagnosed with TD2 are insulin resistant. So that's the problem with type 2. You do have insulin, your body just doesn't know how to use it. Some of the complications are alterations in your blood glucose levels, alterations in your cardiovascular system. Again, this list looks like a little bit like type 1, neuropathies, your dental problems, issues with your feet, issues with your kidneys. And then it talks about a condition, hyperosmolar hyperglycemic state. And this occurs in individuals who have type 2 diabetes, and it's characterized by a plasma osmolarity of 340 or greater. The normal range is 280 to 300. It's greatly elevated blood glucose levels, more than 600, and often as high as 1,000 to 2,000. That's terrible. Altered level of consciousness. With this condition, it is serious, life-threatening medical emergency. Mortality is high, even higher than that for DKA. Because the metabolic changes are serious and because individuals with diabetes usually are older and have other medical problems as well. The precipitating factors that are associated with HHS include infection, therapeutic agents, therapeutic procedures, acute illnesses, chronic illnesses. The most common precipitating factor is an infection. The manifestations of disorder may be slow to appear, with onset ranging from 24 hours to 2 weeks, and they're initiated by hyperglycemia, which causes increased urine output. With increased output, the plasma volume decreases and glomerular filtration rate drops. So when this filtration rate changes, glucose is retained and water is lost, and so you have glucose and sodium accumulating in the blood, which increases the osmolarity of the blood and makes you more susceptible to metabolic changes. You can have severe dehydration, including in the brain. You have dry skin, mucous membranes, extreme thirst, altered levels of consciousness progressing from lethargy to coma. Neurological defects include hyperthermia, motor and sensory impairment, positive Babinski sign, and seizures. Metabolic acidosis is not part of the patho despite elevated blood glucose. Sufficient insulin is present to prevent metabolism of fats, so you don't become like you would if you were having DKA. And I just want you to know what this is. I don't want you to have to know it quite this detailed. But as a nurse, you definitely need to be checking patients' urine output and complaints of thirst and things like that. So how do we treat it? Similar to DKA, establish and maintain adequate ventilation, correct shock with IV fluids. If the patient's comatose, institute a nasogastric for suction to prevent aspiration, IV isotonic and colloid solutions, administering potassium to replace those losses, and administered insulin if the sugar's over 250, you want to get down. And so you see the information here on your slide as well. Our collaboration treatment of patients with type 2 focuses on maintaining blood glucose at levels as nearly normal as possible through medications, dietary management, and exercise. The primary care providers are able to care for patients with type 2. However, collaboration requires many resources. Depending on the available resources and the patient's needs, the interdisciplinary team may include a certified diabetes educator. And you really want to go see someone who is well trained in diabetes that can help you with meds and diet and an exercise program. You may have GI problems, so you may have to have surgery for morbid obesity as well. A lot of these patients have acid reflux issues as well because of the weight. Some of the diagnostic testing who are asymptomatic should be considered for patients who are overweight or their BMI is greater than 25. So I said a while ago 30, but your book says BMI greater than 25, so we'll go with the book. All patients, however, should be tested at the age of 45. If testing is normal, they should repeat it. Tests used to screen type 2 include measurement of your glycosylated hemoglobin, which is your A1C, and a 2-hour sugar test, and then the oral glucose tolerance test as well. Some of the pharmacological therapies usually able to control glucose levels with an oral hypoglycemic medication, but they may require insulin at some point. Patients with TD cannot be treated with oral medications during hospitalization because of the risk of hypoglycemia from not eating and the slow response of these medications to correct hyperglycemia. So they may need something IV to get it corrected. There's growing acceptance of the need to achieve tighter control of blood sugar in individuals who are hospitalized with hyperglycemia, whether they are diagnosed with diabetes or not. There's no clear evidence for specific goals for hospitalized patients who are not critically ill. So, you know, there's a lot of research going on about diabetes and how we need to manage it to keep those levels within normal range. So when we look at hypoglycemic agents, these are used to treat individuals with type 2. They lower the blood sugar by stimulating or increasing insulin secretion. And so some of these drugs are like your metformin, and it also listed Victoza, and that's an injection. They listed like your hormones which play a significant role in insulin secretion, and some of these would be things like Victoza. Victoza is really not an insulin, it helps the hormones do their job is what it does. And this is done by injection. These type of drugs help stimulate insulin and amylin secretion from the pancreatic beta cells, and we know how the beta cells work from listening to the lecture on type 1 diabetes. And so when you're looking at the medications, you know, a lot of these, they are injection, they are to help the hormones do what they need to do. And there's a multitude, you know, I mentioned before I take a shot and I take Ozempic. And let's see if there's anything I missed here. I feel like I missed something here. Let's see. Okay. And I'm just reading through to make sure that I didn't. Yeah, one of the other drugs is Januvia, and you may see see those commercials on TV. It talks about exercise and losing weight and, just getting out walking, being as active as you can. One of the reasons we're seeing it in children is because of their diet, and they're overweight, they're inactive. And I'm not beating up technology, but a lot of kids spend more time on technology just sitting around with their tech toys, and they're not out moving around. So when treating children and educating them, we need to talk to them about exercise and modifying their food choices, and really focus on nutrition and their caloric intake. And a lot of kids eat fast foods and things like that, and that don't not just have high calories and high carbohydrates and sugars in them. It makes you gain weight and thereby increasing the obesity. It says children with a BMI greater than the 85 percentile for age and sex should be counseled. And so, and it's very hard, like I said earlier, it's hard to work with children. Some of the pharmacologic therapy for children. It lists metformin here. Glucophage is a good one that they use with this age group. It says successful maintenance of glycemic control depends in part on frequency of glucose monitoring. Be sure to assess for frequency of monitoring at each patient interaction. So, these, whether they're an adult or a child, they need to have their sugar checked if they're at risk. It said if the pediatric patient experiences ketosis or severe hyperglycemia, random PG concentrations greater than or equal to 250 or an A1C greater than 9, and that's really high. We saw in the other chapter that the A1C greater than 6.5 was considered diabetes type 1. So if you're at 9, you're going to have some liver damage, and you're going to have an enlarged liver as well, and that's not going to be good. In pregnancy, this is called gestational diabetes, and it can be treated with diet and oral medications. Sometimes it's hard to treat it during pregnancy just because of the added amount of caloric intake, that the mother needs, during the pregnancy. Recommended weight gain during pregnancy for an overweight woman is 15 to 25 pounds and 10 to 20 pounds for a woman who is obese. And so, really before considering getting pregnant, they may need to consider, losing some weight and stuff. And some of the comorbidities that exist with pregnancy and type 2 is hypertension and fetal loss during the first trimester. And that can be very devastating. For older adults, besides complications found at a younger age, also at high risk for other things, polypharmacy, using multiple pharmacies to get medications, functional disabilities, cognitive impairment, urinary incontinence. And so, it says make frequent assessments to monitor for symptoms of HHS in the older adult who has had major surgery, because we saw, earlier talking about HHS that having surgery was one of the things that could spin you into that. The nursing process, it is similar to that for type 2, type 1 diabetes. So you want to observe the patient with any outward signs of complications during the interview, determine which medications are prescribed, and review the glucose log. Make sure they're checking their blood sugar, talk to them about their diet, especially the carbohydrate intake and the sugar intake. Have they lost any weight? What's their exercise program? Are they urinating a lot? Look at their meal times and their patterns of mealtime behavior. What are they eating? And it's also the same thing for children. Look at their vital signs, assess their fingerstick blood sugar, look at their skin. Is it dry and cracked? And do they have issues with their skin? Some of the goals describe how to administer meds, respond appropriately to side effects, and we know that these meds, can lower the blood sugar, so you have to assess for hypoglycemia. Demonstrate meal planning compliant with the ADA diet. Give them some information from the ADA website on the diabetic diet. More fruits and vegetables, no sugar soft drinks and sweet tea and things like that, and the good stuff, cake and ice cream and donuts. We try to get sugar free as much as possible. Teach them how to monitor their blood sugar levels and teach them strategies for reducing infection. And one of the biggest things, again, is to lose weight. The interventions are similar to type 1, and there were multiple listed in that chapter. Teach them how to self-monitoring of their blood glucose, how to do a finger stick blood sugar, and what the ranges are. Remember, your book said 70 to 110 was normal range. And teach the family also to recognize the signs and symptoms of this hyperosmolar condition. Again, hyperosmolar hyperglycemic state, or your HHS, is life-threatening, and it said it's worse than DKA. And then the expected outcome: patient demonstrates age-appropriate understanding of diabetes self-management. Patient skin integrity remains intact. They remain free of infection, remains free of injury. If the outcome's not met, then we reassess the diet and medication adherence and try to reassess their ability to lose weight.